dia! Estou começando o programa Infertilidade em Foco. E hoje teremos um convidado que irá representar o país Egito, Dr Khaled Elnomrosy. Ele que é ginecologista, consultor na área de reprodução e fertilidade e membro do Conselho de Ginecologia no Egito. Dr Khaled é proprietário da clínica Elnomrosy, clínica de fertilidade. E também doutor e consultor na clínica Novo Oriente, clínica de fertilidade. E hoje irá tratar um assunto muito interessante: a implantação do 5º dia do embrião Blastocyst no útero para ginecologistas e embriologistas. Vamos assistir?
Hello everybody, my name is Dr Khaled Elnomrosy. I'm a consultant in gynecology and OBGYN, and also I'm a lab director in the Middle East Fertility Center in Cairo. I had my FRSOG, my fellowship from the Royal College of Obstetrician and Gynecologist from England, and also I have a master degree in assisted reproduction in the IVF lab from Nottingham University, and I have been working both jobs actually since 2000, since I came back from England and I started our own center, and I'm a lab director. At the same time I am a clinician. That will give me the chance actually today to explain the topic of our discussion today, which is embryo transfer on day 5 and why blastocyst. That will give me the chance to explain it from the clinical point of view, from the gynecological point of view, and also from the lab point of view. So we'll start now from the lab point of view, why we choose to transfer and why actually the blastocyst transfer is much better from the lab point of view than the day 2 or day 3. In the 80s and 90s, we used to transfer all the embryos on the day 2 and day 3. Before we discuss that, I would like to explain the division. We know that in the first day there is a 2pn stage, and then 2-cell stage, and then 4-cell stage at day 2, day 3, 8-cell stage, and after day 3 they will start to multiply to reach the morula, and then will reach the blastocyst stage. In the 80s and 90s, as I said, we used to transfer all the embryos in day 2 or day 3, and we were happy with the results. But then David Gardner came in the late 1998, 1999, and he invented the blastocyst transfer, and it was a booming issue. It changed the whole practice. At that time, he discussed that the requirements for the embryo before the 8-cell stage is different than the requirements for the embryo after the 8-cell stage. For example, you will find that more glucose, for example, on the morula and the blastocyst stage than before that, and so on. So he invented his culture to start on the step 1 the requirements that will embryo till the 8-cell stage need, and then in step 2 culture media different requirements for the embryo, and that went well, and the blastocyst came up. Now we realized that why we doing that, because if the embryo if we put all the requirements for the embryo on one culture media, and then he will select whatever he wants, then the single step one-step media came up, which became more convenient for the embryologist, as he will put the embryo on the day 1, and then, well, if he's confident enough with his lab conditions and his incubators and so on, he will open it up on the day 5 or day 4 to assess the embryos. That will save him taking out the embryos from the incubator and putting them on, and change the pH, change the CO2, the temperature, and so on. So we were happy, we are very happy with our step 1 single step media for the blastocyst. Also, if you are aiming for the blastocyst on your lab, then you will have to have a triple gas incubator, and actually it will take a hassle. I will take more work and more dedication to develop a blastocyst in your lab. But once you get a blastocyst in your lab, that will some sort of a certificate that your lab is okay. And according to the percentage of the blastocyst you are getting, that means you are improving. So you are always aiming to have a blastocyst in your lab from the embryology point of view, and for the sake of the lady, and actually for your lab practice as a whole. Now, why is that? Why is the blastocyst from the lab point of view is much better than the day 2 or day 3? Now, for the division and the cleavage of the embryo in the day 2 or day 3, it depends the embryo on the maternal genome. It's not doing anything. It's depending on the maternal genome for its division. After the day 3, then it starts to depend on its own genome, on its own embryonic genome. And that is why the whole turning point starts after day 3. The whole crux, the whole, like earthquake happens after day 3. Sometimes you have a very good, as you think, very good 10 embryos on day 3. And then you look them at day 4 and you will find only 2, 3 start to progress and start to perform blastocyst. That's because these embryos were not a good embryos to start with. They are deceiving us. So when they start to depend on their own genome, then we'll find a good embryo from the bad embryo. So from the lab point of view, blastocyst is much better than day 2 and day 3, and you always aim for it. As long as you have a good embryos and enough number of embryos, and as long as you are confident with your lab conditions. From the point of view of the clinician, why day 5 is much better? We are not used to see it now anymore because of the I'm talking about the hyperstimulation syndrome, because of the antagonist and because of the different protocols and different measures you take now. We don't see hyperstimulation very much, but if you do, then it's benefit to much better to start to day 5 to give you a better chance to evaluate the lady, make an ultrasound for her, and if you're suspecting you are going to have a hyperstimulation with her, then you will freeze all and transfer on different cycle. The other good point about day 5 is that you, if you have a thin endometrium, for example, and you want to give her more drugs to make the endometrium much better, then you will have a 5-day, then you will have a 5-day much better than 2 days or 3 days to prepare the endometrium and make the endometrium much better to transfer. The other thing is the clinically, if the lady is, for example, tired from the whole journey of the stimulation and the pickup and so on, so she will have a rest for 5 days and she will clinically be much better. You can reassess her, you can do an ultrasound. As long as you did not transfer the embryos, you are in control. You can freeze all and then transfer on another cycle. Once you transfer these embryos, there's nothing you can do about it. So in that way, the clinician will prefer always to go for day 5. But the main issue for the day 5 transfer that actually changed the results, besides the quality of the embryo, is what's called the window of implantation. Because once you transfer the embryo into the endometrium, into the uterus, the embryo will start sort of conversation, discussion, negotiations between the embryo and the endometrium to let it, let it implant. So this window of implantation is much better on the day 5, and that's what actually changed the results. It's not only that you are transferring a good embryo and you are confident with your embryos that you are giving the clinician, also the clinician is quite happy because he is sure that the window of implantation is in day 5. So that's why the results is much better than day 2 and day 3. So from the clinical point of view, clinicians always glad or happy or aiming for day 5. transfer. That's as regard for the fresh transfer. Now, also the blastocyst stage is very important if you decide to do a PGTA or what you call a chromosomal analysis for this embryo for one reason or another. For example, if she is having a hereditary disease, she is suspecting of a certain genome to be affected. If she is over 40 and she's worried to have a baby with anomalies and all sort of things, and you decided to do a PGTA or to do a chromosomal analysis for this embryo. We used to do it on day 3 actually, because on day 3 there was the 8th cell stage, and they are not quite, the embryo, the cells are not very attached to each other, so it's easier to detach one and analyze it. But actually the results were not very good, and we have also the nightmare of the mosaicism. That's actually, you have a disease that is not dominant, you will not discover it. When the blastocyst came, you actually taking the biopsy from the trophoectoderm, so it is much bigger biopsy. It's much more informative. It avoids mosaicism. It's much reliable results than day 2 or day 3. The only problem is that you cannot transfer it on the same cycle. So you have to take the embryo and take the biopsy, analyze it, and then freeze this embryo, and then when the results come, you transfer it on the next cycle. So as far as the PGTA is concerned, the blastocyst, I don't think anyone now in the world doing day 3 blastocyst biopsy. We are doing the blastocyst biopsy. One last issue about the transfer on the blastocyst stage is the frozen transfer. The frozen transfer, when you freeze blastocyst, is much better than you freeze day 2 or day 3 embryos, because you have, as I said, you are very confident with your embryo. When you are starting to discuss with the lady if you are going to transfer it later, you are much confident with the results of the embryo when you thaw it after that, and you are it will take much more effort from you, yes, but the result is much better when you freeze blastocyst than when you freeze day 2 or day 3. A country like ours in Egypt, not very economically well settled, we depend on the freezing very much because the cost is very high for these procedures. So actually, when you start stimulation, a lady for IVF or ICSI, you are putting your eyes on freezing. I want to, whenever I get a chance, I really want to freeze an extra embryos for this lady to avoid these excessive charges on the later on trials. Therefore, if you freeze a blastocyst, then you are confident when you are counseling her or when you are discussing with her that these embryos will most probably be all right when you thaw them. So you are not giving them like a false hope or something. And most of the ladies will come from other, very far away, and it's very frustrating when you start stimulating them or start preparing them for the transfer, for the frozen transfer, and they come all over, and then when you thaw the embryos, you will find that these embryos are not dividing as you expected, or they are dead or something. For the blastocyst, the results for the freezing is much better. The survival rate is much better. And again, the window of implantation is much better, so that's for the results. That's all for the embryo transfer as a blastocyst, because one final thing for the embryo transfer as a whole. Embryo transfer is a very crucial step in the procedures of the IVF or ICSI, because that totally depends on the skills of the gynecologist for his or her skills to transfer the embryos, and that will change the result tremendously between different hands. Therefore, we respect very much the procedures of the embryo transfer during the IVF or ICSI. And from the lab point of view, I would like to give this gynecology and this lady after all this journey a very good embryo. That will be achieved by giving him or her a blastocyst rather than day 2 or day 3 embryo. That's all for our topic today. I hope I benefited you in somehow, and I hope I will see you soon. Thank you.
O programa Infertilidade em Foco traz para vocês os melhores especialistas em reprodução e infertilidade do mundo todo. E hoje, representando o Egito, Dr Khaled Elnomrosy irá nos conceder uma entrevista exclusiva, diretamente do Egito para o Brasil. Vamos assistir.
Hello everybody, my friend Bell, which is actually a very good friend of mine, she has sent me a few questions to answer in this interview. The first question is...
Dr. Khaled, quais são os tratamentos que você acha mais adequado para tratar a infertilidade?
In Egypt, we start with follow the protocols of the stimulation, and then ovum following stimulation for the ovaries, and then if not succeeded, we proceed to IUI, intrauterine insemination. If not, we can do IVF or ICSI. These are actually the steps of treating infertility in Egypt. But a very good portion of these patients will get pregnant by actually just monitoring ovulation and advising them with the proper time of intercourse.
A infertilidade é uma doença mundial. 1 a cada 6 casais são inférteis. No Egito, qual a principal causa da infertilidade?
In Egypt, male infertility or male factor becoming a very the percentage of male factor than the female factor is very high. We are a hot country. Most people having a varicocele, having issue with the sperm production, and we noticed after the epidemic of corona, the male factor has by far increased. So we have a problem here actually with the sperms and the mainly with the not with the number of the sperm, but with the malformation of the sperm itself and the athenospermia. The other issue of the infertility in Egypt is a marriage. The age of marriage is becoming now delayed. So they are becoming older and older. So the male factor, it might be increased, but not like a male factor. But the main issue is the age of the marriage now is not as young as it used to be in the past. Therefore, the issue of freezing the oocytes is becoming more and more popular in Egypt. So she can freeze her oocytes when she get married. After a few years, she can thaw them and inject them with the sperm.
A fertilização assistida foi implantada no Egito em 1986, quando foram criadas várias diretrizes de acordo com a fé islâmica. Hoje, atualmente, como está legalizado a fertilização assistida no Egito? E há alguma limitação em algum procedimento?
In Egypt, we have a very good proportion actually of Christian. It's almost 85 to 90% Islamic, but the Christian is 10 to 15%. So there is a very respectable proportion of Christian in Egypt. And gladly enough, or luckily enough, whatever you wanna, however you wanna see it, both actually Christianity and Islamic, it's guided more by culture of the country, agreed on most aspects of the infertility treatment, like both the condemned for example, donation, whatever sort of donation, or size donation, sperm donation. They condemn uterine renting, to rent a uterus and somebody else to rent the uterus for somebody else. Both Islamic and the Christian will repel that, and there actually laws became providing, and according to this point of views, the laws become to reinforce these point of views. Otherwise, we have everything else as anything else. We treat them and we make sure that it's the same sample. And here is the concept actually for the Christian as well as for the for the Islamic point of view. We don't have like they have to be married. We don't have the sort of boyfriend and girlfriend, and they have to go and to the clinic and try to have a baby. It doesn't matter. Both religions agreed on that, and there is a law against that. They have to have, sort of document of marriage to have the procedures done or to have the treatment done. We're talking here about IVF or ICSI. Other things in Egypt for the infertility is the sort of there is no rules for how many embryos you will transfer, because we are not a very rich country, and we don't select, we don't confine you have to have 2 or 3 embryos transferred. No, you can transfer as many as you want. And people here are quite happy with multiple pregnancy. Actually, if they will be happy to have a twin pregnancy. If they have more than 2, we do embryo reduction. It's not against the law, but if it is 2, they are very happy because she will not have to try again. That's how they see it. She will have a 2 baby with 1 trial. That's how they see it, because economically it is frustrating and it's very exhausting to have this trial again. So we don't have a law here to determine how many embryos to do. The other things are quite the same as any other country. We stress on freezing here. We love freezing because, again, for the economic point of view, freezing is a very, very hot issue here.
Eu vou dizer 3 palavras e você me diz o que vem em sua mente. Infertilidade, blastocisto, reprodução assistida humana.
She's saying here, I'm going to tell you 3 words and you tell me what comes to your mind. Infertility. Infertility is, I don't like the expression actually, infertility. It's a very harsh, very hard expression. I call it subfertility, or problem with conceiving, or any other things. But infertility is a very tough word, and definitely is a very tough experience for any couple to have such a problem. It's a very devastating. It's a very challenging to overcome, and you have to have faith. You have to have faith to go through the procedures to treat such a problem. The other word is blastocyst. I had a video before talking about how much I am a big fan of a blastocyst, and I think it changed the whole practice in our practice in IVF and ICSI, and many couples will be thankful for the blastocyst stage, because it changed the results tremendously. The last one is human assisted reproduction. Human assisted reproduction is I think it's a very good job. It's a very hopeful job. I'm very glad to be subspecialized in such a specialty, because nothing compared to the happiness of a couple after long struggle to have the news to have a baby. There is no cost for this feeling or for this joy or happiness to see such a couple having such happiness. So I think it's the best job in the world. Thank you very much.
Olá, meus amigos. Chegou a hora de sanar dúvidas de vocês. Vamos começar? A primeira pergunta de hoje. Sandra Porto, do Rio de Janeiro. A Sandra quer saber o que é uma barriga solidária. Bom, Sandra, a barriga solidária consiste em uma mulher que vai emprestar o seu útero para que um casal gere um filho. Como que é feito esse processo? A pessoa que vai ser a barriga solidária, que vai emprestar o útero, tem que ter pelo menos um filho vivo, ter grau de parentesco consanguíneo em até 4º grau. Caso não tenha nenhum grau de parentesco, tem que ser autorizado pelo Conselho de Medicina. Daiane Sampaio, Maranhão. Doutora, me tira uma dúvida. Como funciona a FIV, a fertilização in vitro? Bom, Daiane, é retirado o óvulo, depois junta esse óvulo com o espermatozoide, fecunda fora do útero, fora do corpo, em um recipiente de vidro, por isso é chamado in vitro, que foi uma das suas dúvidas. E após essa fecundação, no 5º dia, após as células se multiplicarem e formarem o blastocisto, é implantado o embrião no útero. E daí o desenvolvimento é normal, como se tivesse fecundado dentro do corpo. Rosiane Souza, Paraná. Tenho 35 anos. Fui ao médico que me indicou uma mini FIV, uma mini fertilização in vitro, mas não explicou o que seria. A senhora poderia me explicar? Bom, mini FIV ocorre da seguinte forma. É usado uma dosagem menor hormonal para estimular o ovário a produzir os óvulos. Com isso, o custo-benefício também é menor. E a quantidade de óvulo estimulado é de 1 a 4. Vai ser menos óvulos, mas talvez a qualidade seja ainda melhor. Estou encerrando o programa Infertilidade em Foco. E quero agradecer ao Dr Khaled Elnomrosy pela sua participação e por ter contribuído com tanto conhecimento conosco. Também quero agradecer aos telespectadores por estar assistindo todos os domingos o programa pela TV Faz Brasil. E continue enviando as suas dúvidas que eu estarei respondendo para vocês. Até o próximo programa.